Hello and happy Thursday. A little addition to our usual Tuesday greeting. My name is Lisa Houston, and I am a clinical nurse educator specializing in NICU education. And as a NICU Nurses Week bonus, I am here with part 2 of congenital anomalies. If you tuned in for part 1, you saw some of the risk factors and what it means to be called a congenital anomaly. So remember, this is something that happens in utero prior to the baby being born. It may have to do with their genetics being laid differently or something we saw in the limb differences with amniotic banding. Today, we are going to go through a couple of things, and I'm also going to only briefly touch on 2 things that we have done previously. When we get to those slides, I will remind you that you can go back and look at previous Teach Me Tuesdays. So let's start with myelomeningocele. A myelomeningocele is the most severe form of spina bifida, where the spinal cord and surrounding structures don't close. And one of the contributing factors for this is a folic acid deficiency, which is why all pregnant women take a multivitamin high in folic acid during their pregnancy. It's interesting because we now can do in utero surgery for these babies. I've actually seen one afterwards. They were born at 34 weeks. They had had surgery during mom's pregnancy. It was pretty fascinating. I was like, oh my gosh, this is the first time I've seen this. So just something to think about. If not, if you were at the delivery, we do create little kind of like circle, donut kind of halo shaped padded circles to go around for when the baby comes out. And we can keep that area in a dressing prior to them going to surgery. So surgical repair is performed soon after birth. There's going to be issues primarily with mobility, bowel and bladder. Could have hydrocephalus. It is not always, but it could be a potential outcome. So something that may need to be addressed, whether that ends up with a shunt or whatever goes on with the baby. But those are things, think spinal cord, everything's kind of connected there. You can see here where that cerebral spinal fluid is going in the picture of this baby. So something just to think about as you are treating this, even if it has been repaired in utero. I remember specifically the baby I took care of. This was out in my previous employment in Seattle. And we focused a lot on when was she having her first urine? How was her stool going? Was she kicking her legs when she came out? So just something to think about, especially if they've had in utero surgery. We're going to go through 3 trisomies right now. Yes, there are more than 3 trisomies, but these are the primary ones that I have seen throughout my career as a NICU nurse. So trisomy 13 is also known as Patau syndrome. It's associated with severe intellectual disabilities, congenital heart defects, and brain or abnormalities. These babies typically have a very short life expectancy. This might be a baby that you know that the parents are not going to want extensive resuscitation at birth. These might be some babies that do come to the NICU for a brief time and either pass in the NICU or go home on some sort of palliative or hospice care. Yes, the babies can live for typically up to a year. There are always outliers. I never like to say, oh, these babies only do this. You know, I don't believe in the black and white. So in the gray, there's going to be a spectrum of this life expectancy, but expect for it to be short, sometimes only even hours. So that's something that you might need to be thinking about. Maybe you do on your unit have some sort of palliative care or heart prince care, end of life care, where you have one baby in the NICU and one baby on labor and delivery. And so this is the baby you're going to check on and help their parents through their grieving. So you can see pictures of this. I did not want to put pictures in here of these babies. I really want us to just focus on what it would look like, what to expect with the baby and what you expect the care to look like. So trisomy 18 is another life-limiting diagnosis. This is also known as Edwards syndrome. I do sometimes get these 2 a little bit confused. That's why I wanted to make sure we put them in here. Oftentimes, I see more trisomy 18s live a little bit longer. That's just my personal experience. I do not have the statistics on which one lives longer, but it does result in significant growth restrictions, intellectual disabilities, and life-threatening organ malformations. Also with trisomy 13, the one we just talked about, depending on the heart defects, because likely the baby is not going to get any sort of cardiac surgery, that is a part of that life limiting. With trisomy 18, there are some surgeries involved. I have seen a baby go home with a G button with trisomy 18, but often we're going to focus on care, comfort care, whether that's getting the baby home into hospice or doing that in the hospital. Trisomy 21, we all know a lot about this, Down syndrome. I love the phrase, there's nothing down about it. This is that distinct physical characteristics. Some of these babies will have cardiac defects, often a VSD. Depending on the severity of it, they might need oxygen at birth. They might need oxygen when they go home prior to the closure. They might need speech therapy, physical therapy, occupational therapy, but these babies do have long and fulfilling lives. When I was born, this was considered still a life-limiting disease. Often we weren't able to repair the hearts, or they weren't repairing the hearts, and now these are just some of our favorite babies and our friends and our neighbors that are around. So trisomy 18 and 13 are more of our life-limiting trisomies, whereas trisomy 21, we have made a lot of advances in the care of these patients. Omphalocele versus gastroschisis. So both of these are congenital anomalies, but we have gone over a whole Teach Me Tuesday comparing these two to each other. So I just wanted to put them both on one slide so you can see them. So remember, with an omphalocele, the abdominal organs are outside of the baby, but they are covered by a membrane. It's really important to remember that, because that's kind of a distinguishing characteristic. Whereas gastroschisis is the abdominal wall doesn't perfectly close, and so out comes the organs, often the intestines and all that, and it's just kind of like free flowing. We put them in a bowel bag. That's what you would do as a delivery nurse. You would be prepared for a sterile placement in a bowel bag. Omphaloceles sometimes reduce on their own, and we take time to do that. They don't often go right to surgery right away. We give it time to kind of go down. We had a baby go home once I had a giant omphalocele. As they were waiting for it to come down so that the skins could stretch, the baby went home on dressing changes, and whereas gastroschisis, they get a silo or surgery right away. So that's another difference. So omphalocele has a covering. Often they can go home or not need surgery right away, might be in the NICU with a repulgal, might start feeding depending on the severity, whereas gastroschisis, we get these babies through surgery right away. I saw a baby go down to surgery within the first hour of life, and they do not have a sac, and they're at high risk actually of fluid loss, you can imagine, because of this exposure, temperature instability, fluid loss, because the organs are just outside with nothing covering them. Again, a previous Teach Me Tuesday, it was back in 2023, kind of one of my originals, so be gentle with me if you go back and check it out. Cardiac anomalies. As I mentioned on Tuesday, 2 days ago, we've already covered cardiac anomalies, congenital heart defects extensively in February, where we went through 4 very specific ones. We've talked about intra to extrauterine circulation, but this idea that a congenital heart defect is something that is happening in utero, the definition of congenital. So just some examples would be anything from a VSD to tetralogy of Fallot, transposition, hypoplastic left heart. That's what we have a picture of here, is this hypoplastic left heart. I really like to remind everyone that the left ventricle's main job is to be the big pumper, the most forceful thing out of there. That's what gets the blood up against gravity into the ascending aorta, into the aorta, and out into the rest of the body. If that left ventricle is inhibited from being able to do that big push and push the blood out, you can imagine that the baby would have some detrimental effects from that. So I always like to point that one out, because it is a pretty life-limiting one if it is too major or the baby cannot get a heart transplant. Some treatments for some of these diseases might just be medications. We might do PGE until they go to surgery. They might need diuretics. They might need oxygen. We have kids like with TET, some TETs go home and they grow for a period of time before they get their heart surgery. They may need cardiac catheterization to do a minor repair of an ASD or a PDA. A PDA is considered a congenital anomaly if it doesn't close over time. And then surgery. So tetralogy of Fallot, they might go right away. Hypoplastic left heart often goes on ECMO first. And transposition, surgery right away. They are often staged surgeries. So go back, watch the February Teach Me Tuesdays, check out my Instagram from the previous Teach Me Tuesdays, and see kind of the fallout of all of those different ones. So I mentioned we were going to go over parent education. I wanted to really just touch, I'm going to do 2 slides just on parent education. Remember, no one goes into a pregnancy thinking something's going to be wrong. So maybe they hear about this early in their pregnancy, maybe at that 20-week anatomy scan, they've noticed limb differences, a heart defect, a cleft lip, a gastroschisis, something could be going on. And so what can we do to help them understand this change? Is that a visual aid? Is that saying, this trisomy is probably life limiting? Should we do amniocentesis? Should we see what's going on with the baby? Let's talk about palliative care. Can we get them connected to genetic counselors, support networks, people that have gone through the same thing, so they have someone to talk to about their situation? Many of these babies that we have gone over in the last 2 days will have extensive follow-up with many different doctors. Having a navigator, someone in a role that's really going to connect them in all of these different appointments, will also be crucial. For babies with limb differences, we might need to talk to them about how to hold and care for their baby. Will they need a prosthetic? What will that look like for the baby? How can we help get the baby rolling and pushing up and doing all of those things? And just having some safe handling with them. For oral facial anomalies, a lot of this is going to be teaching about feeding and safe sleep, positioning, making sure that they are able to breathe effectively. But long-term feeding is going to be a huge part of craniofacial anomalies. So get your therapy team involved early and often. Cleft lips and cleft palates, sometimes go home before they're, most of the time, go home before they're repaired now. That's like a big part of this. This is a surgery, as we talked about on Tuesday, between 3 and 6 months. So we need to make sure that they can safely breast or bottle feed their baby prior to going home. Think about your TE fistula. That is going to require surgery. Not all TE fistulas are known ahead of time. So think if this is found in the NICU or found in the immediate postpartum period, this is going to be a big change for them. The baby's going to be admitted to the NICU. This happened recently. We had a baby born in a birthing center who came to the NICU for respiratory distress, unable to pass the feeding tube, got an x-ray. The baby had a TE fistula. Talk about a big traumatic change for a parent who was in a low intervention birth and now is in the highest intervention, the NICU, baby needing immediate surgery, having a Rapolgol, having this prolonged feeding tube. It is a big change for them. So normalizing that this trauma is normal, listening, not listening to respond, not listening to be toxically positive, but listening to say, I hear you, I understand that this is a change for you, I'm going to walk alongside you. This limb difference is not something you were expecting. It's okay to grieve what you thought was going to happen. How can I support you? Instead of saying, oh, it's just a limb difference, they've got another arm, they're going to be great, everyone's going to do fine, or, oh, I see tons of kids with cleft lip and palate, they're going to do great, you don't have anything to worry about. They do have things to worry about. This is not what they had planned for their child, so always keep those things in mind with these congenital anomalies, whether they knew about them in utero or after. This is a big change for them, and they are going to be grieving that which they thought was going to happen. So to recap all of these that we've talked about over the last 2 days, we've talked about T fistulas, craniofacial differences, myelomeningocele, trisomies, congenital heart defects, omphalocele, limb differences, lots of different ones we've gone through. They can be mild to life-threatening, many immediate interventions. Sometimes that's surgical interventions. Sometimes that's immediate palliative care interventions, which can also be extremely scary for families. Early diagnosis, tailored plans of care with frequent check-ins with parents. I think about that a lot with our trisomies. We can't just assume with a trisomy 13 or 18 that they're going to want to continue on the plan that they initially picked. Maybe they change their mind, and we'll be there to support them as they do that. Educating our parents so they can understand their baby's condition and what the treatment options are. Grief counselors, support groups of babies with similar diagnosis. I do think when you think about my career, I've been a NICU nurse for over 20 years. This idea that like 20 years ago, social media was just starting. I know, brace yourselves for how old I am. But now in social media, they can find these support groups. They can find other people who have gone through things with them, connecting them there, finding resources to evidence-based practices for their babies is going to be phenomenal for them. You get to be their advocate to help them find what they need to best support them during their NICU stay. So thanks for joining me this week during Neonatal Nurses Week, NICU Nurses Week. I absolutely cherish each and every one of you, and I'm so privileged to be able to call myself your colleague. Thank you for all of your hard work. I hope that you know that you are treasured and honored, and I am just so proud of you for continuing your education and for being a part of this NICU team. And I will see you next week for another Teach Me Tuesday.